Good evening, ladies and gentlemen. Welcome to Day 4 of the Asian Oncology Society Conference. To open today's session, please welcome Dr. Ying Wang, Secretary General of AOS and Secretary General of China Anti-Cancer Association.
Good evening, ladies and gentlemen. It's my great honor and pleasure to chair the Philippine Cancer Society special session, The Challenge of Managing Gastric Cancer in Asia today. My name is Ying Wang, the Secretary General of AOS, as well as the Secretary General of China Anti-Cancer Association. As everybody knows, gastric cancer is the most common disease spreading over the world, especially in East Asia. In 2014, the overall gastric cancer incidence in East Asia was approximately 4 times higher than other regions of the world. The gastric cancer is still one of the main common types worldwide. Given that critical prevalence, we must face the challenge and pay attention to the prevention and treatment of gastric cancer. In recent years, the oncologists and researchers in Japan, Korea, and China has made great contributions to decrease the incidence and improve the survival rate of gastric cancer in Asia. The preliminary achievements obtained by screening and early diagnosis and treatment. Here today, Professor Kazuhiro Yoshida, the famous gastric oncologist in the world, will share his perspective and experiences about gastric cancer management with us. Professor Yoshida comes from Japan. He is the Secretary General of AOS. He is also the professor and the chairman of the Department of Surgical Oncology at Day4 University and the chair of International Committee of the Japanese Society of Gastrointestinal Surgery and the Japan Society for Clinical Oncology. He is a member of the board of directors of the Japanese Gastric Cancer Association, Japanese Society of Gastrointestinal Carcinogenesis, and the Japanese Society of BRM, etc. Ladies and gentlemen, let's welcome Professor Kazuhiro Yoshida to give the presentation.
Good afternoon, ladies and gentlemen. It is my great honor and pleasure to be able to talk this afternoon about the challenges of managing gastric cancer in Asia. Before my talk, I would like to congratulate Professor Marilyn Salmon Fernando, the overall chairperson of the AOS 2020, and Professor Crystal Lunar, Congress President, and all the organizing committee of the first AOS meeting in Manila. And I would like to pay special admiration and thanks in preparing this important meeting in COVID-19 pandemic situation. Gastric cancer is a heterogeneous cancer with widely varied outcome with similar clinical pathological features between Caucasians and Asians. The treatment result of Asian countries seems to be better than those of Western countries. It is an urgent need to clarify what is the difference and what is the best management of the patient with gastric cancer in East and West. So topics today are firstly, genetics and biology of gastric cancer in Asia. Secondly, consensus and debated issues on minimal invasive surgery. And finally, focus on updated issues on standard care, including perioperative therapy on gastric cancer. Let me start with the instance of cancer deaths in Japan. And as you can see in the slide, that cancer death is increasing remarkably, and this phenomenon will occur definitely in Asia in the future. Importantly, about half of the population suffer from cancer and 1/3 of the population die from cancer. This slide demonstrates the actual number of incidents of left side and the mortality incidence column. The high incidence, of course, prostate in men and breast in women are remarkably increasing. Concerning the mortality, lung, colon, and stomach is the top three. Concerning the gastric cancer in the world, about 62% occurs in East Asia, and Korea, Japan, and China are the most frequent incidents and mortality. What is the striking difference in the East and West is the difference of the stage at the time of initial diagnosis. As you see that in Japan and Korea, diagnoses are often found at localized or regional. However, in Western countries, it is often found with the distant disease that makes the poor prognosis of the patient. I'm sorry about the complicated slide, but let me talk about the footprint of gastric cancer research in Japan listed on the left side of the slide. In 1980s, oncogene alterations were found in 1990s. Research on tumor progressor genes, genetic instability study were prevalent, and then epigenetic changes. Stem cell research and microRNA data were accumulated. Now, whole genome sequence project demonstrated new gene mutations. As a carcinogenesis step listed on the right side of the slide, Helicobacter pylori played a very important role. Inflammation caused by HB infection contributes to ROS production and abala DNA methylation. The epigenetic changes, such as inactivation tumor suppressor genes and DNA repair genes, finally leading to carcinogenesis. Genetic and molecular alterations during stomach carcinogenesis are summarized in the slide. Genetic polymorphism is a fundamental factor in genetic instability, DNA methylation, histone modifications are early events. After that, multiple genetic and epigenetic alterations are accumulated. Some of these changes occur currently in both intestinal type and diffuse type, and some differ depending on the histological type. All these genetic alterations can potentially be the targets of diagnosis and therapy. Once the cell acquires malignant potential, autoclone growth factors are produced and oncogene alterations are often observed, and overexpression are often associated with poor prognosis of the patients. Now, about 60% of gastric cancer gene alterations have been found. However, the rest of them, the driver genes, are not yet elucidated. Molecular background of gastric cancer is very complicated. This is a very famous slide demonstrating the molecular subtype of gastric cancer by TCZA project, suggesting the possibility of precision medicine in the near future. For example, in the EV virus infection and MSI high population, possible therapeutic merit by immune checkpoint inhibitors. Very interesting, as demonstrated in the right upper side of the slide, the MSI rate differs from organ to organ. However, the response of immune checkpoint inhibitors is very relatively good, and it is accepted on MSI high patient in any organ. Now, the PD-1 antibody is generally accepted to use in gastric cancer in the late line of the treatment. Actually, we have analyzed using Japanese patient with the same analysis of TCZA system on the left side of the slide. As you see that EV virus and MSI population is about 12%, and it is lower than that of Western countries. According to the present analysis, about 40% of patients were identified as driver gene mutations and can be the candidate of precision medicine. And let me introduce very interesting clinical trial demonstrated ESMO 2020. It is the Checkmate 649 study comparing chemotherapy and chemo plus nivolumab on the metastatic gastric cancer as the first line. Surprisingly, the overall survival and progression-free survival of the patient with chemo plus nivolumab was better than those of chemotherapy alone patient, suggesting that future paradigm shift of the treatment strategy in gastric cancer. The slide demonstrates the results of 4 clinical trials concerning the first-line treatment using immune checkpoint inhibitor. However, its role on the first-line treatment is still under discussion, but very interesting point. Okay, let me move on the issue of minimal invasive surgery. Before describing the treatment strategy, let me briefly review the staging of gastric cancer as demonstrated, and it is defined according to the depth of invasion, the number of lymph node metastases, and distant metastases. If the tumor invasion is restricted in the mucosal or submucosal layer, we regard it as early gastric cancer, and if it invades more than muscular layer, we call it locally advanced gastric cancer. This is the algorithm of standard treatment, and in early gastric cancer, ESD or laparoscopic surgery, and in locally advanced gastric cancer, D2 gastrectomy and adjuvant S1 for 1 year is the standard treatment. Endoscopic submucosal dissection is demonstrated in the slide. However, I would not describe precisely this time, but the number of patients treated in Japan by ESD is increasing rapidly. This slide indicates the endoscopic resection by the Japanese gastric cancer treatment guideline. As demonstrated, green zone indicated the absolute indication, and yellow zone indicates expanded indication, and red zone indicate relative indication for endoscopic resection. Laparoscopic gastrectomy is widely performed in Asian countries and recommended as level B for T1 tumor in Japanese guideline. However, its long-term survival has not yet been demonstrated, and also locally advanced gastric cancer randomized trials are ongoing in 3 countries comparing oncological outcome between open and laparoscopic surgery. Recently, the long-term survival in advanced gastric cancer has been demonstrated in China and Korea. However, in Japan, still waiting for the results to be finalized. In the daily practice, NCD using more than 7,000 patients comparing open and laparoscopic surgery in Japan demonstrated that the pancreatic fistula was significantly higher complication compared to open surgery, and so we have to be very careful, especially on obese patients. Now in Japan, we are comparing the short-term outcome between robotic and laparoscopic surgery as demonstrated on the right side of the slide. Now let me talk about the preoperative treatment for locally advanced gastric cancer. D2 lymphadenectomy is the standard procedure for locally advanced gastric cancer in Asian countries. Nose to be dissected is defined according to the type of gastrectomy as demonstrated in the slide. Roughly, D1 is to remove all the perigastric lymph nodes, and if you remove suprapancreatic lymph nodes as demonstrated in blue, we call it as D2. Dutch trial after 15 years of follow-up demonstrated that the survival of patients with D2 was better than that of D1 dissection, and now the D2 operation is also recommended in Western countries as well. If you look back again, these 3 pivotal perioperative treatment trials for locally advanced gastric cancer, D2 was performed commonly in Japan. However, it was not in the West, and this might have been one of the reasons for the different outcome of survival of these 3 pivotal trials. How about extended D2 gastrectomy? As demonstrated, All 4 clinical trials, including paralytic lymph node dissection, left thoracotomy approach, splenectomy, and vulvectomy, were all denied by Jacob study. Adjuvant S1 for 1 year after D2 gastrectomy on stage 2 and 3 patients are standard treatment in Asia because it improves the 5-year survival of the patient about 10% compared to surgery alone, demonstrated on the right upper side of the slide. However, as demonstrated on the right lower side of the slide, S1 alone does not efficient for patients with the multiple lymph node metastasis, especially stage 3 patients. We have conducted and randomized the phase 3 trial comparing S1 plus docetaxel with S1 alone as postoperative adjuvant chemotherapy for curatively resected stage 3 gastric cancer patients, and promising results were demonstrated in ASCO 2018 and published in Journal of Clinical Oncology in 2019. Primary endpoint was 3-year relapse-free survival as demonstrated, and the survival of the patient with S1 plus docetaxel was far better than those with S1 alone in stage 3 patients, more than 15% survival. By the subset analysis, their survival curves demonstrate the same tendency according to the stage 3A, 3B, and stage 3C respectively. As for overall survival, events were not matured at that time, and we are going to publish the results at ASCO GI 2021. The forest plot for a subgroup analysis demonstrate that S1 plus docetaxel therapy is effective for tumor invasion, lymph node status, histology, type of gastrectomy, and location of the tumor. Very importantly, results are demonstrated in the slide demonstrating that the site of first relapse according to the treatment. S1 plus docetaxel adjuvant chemotherapy is very effective for lymph nodes, peritoneal, and hematological recurrences. As for the adverse events, neutropenia and leukopenia are the common side effect, but tolerable, and this adjuvant chemotherapy is regarded as the new strategy for stage 3 gastric cancer by the Japanese guideline. Okay, how about the neoadjuvant chemotherapy? JCOM 0501 study was the most reliable phase 3 study comparing neoadjuvant S1 plus cisplatin and S1 adjuvant treatment on large type 3, type 4 resectable gastric cancer. And as you see on the right side of the slide, that the survival curves were perfectly consistent between the two treatments, showing that the neoadjuvant chemotherapy is not effective in these population. However, in Europe, FLOT4 trial comparing the perioperative chemotherapy with docetaxel, oxaliplatin, fluorouracil, leucovorin versus standard therapy of ECF was presented in ASCO 2017. Very interestingly, FLOT regimen was far better than that of ECF, and it is regarded as standard therapy in Europe. However, if you look at the left lower side of the slide, about 30% of the patients were treated by transthoracic esophagectomy, suggesting that the results cannot be transferred directly to Japanese patients. Another interesting study, ARTIST-2, was presented at ASCO 2019, comparing the adjuvant chemotherapy and/or chemoradiotherapy after D2 gastrectomy in stage 2-3 gastric cancer. Very interestingly, adding chemoradiation was not effective compared to chemotherapy alone. And another important point was that SOX adjuvant was significantly improved the disease-free survival compared to S1 alone. One more important phase 3 randomized study of neoadjuvant chemotherapy was DOS and adjuvant S1, the Prodigy study, was presented at ESMO 2019. The study demonstrated that progression-free survival of neoadjuvant group was better than that of adjuvant group, but interestingly, the progression-free survival rapidly drops down in the adjuvant group. Concerning the survival, as you see on the right lower side of the slide, the overall survival curve is consistent between the two groups, suggesting that no benefit to the survival. If you look at the surgery on the left upper side of the slide, about 15% of the patients was suggested to be the stage 4 patients. And this might have been the reason for the discrepancy of the progression-free survival and overall survival curve. Last interesting result trial was also presented at ESMO 2019. This is a phase 3 trial comparing the preoperative chemotherapy of SOX versus adjuvant SOX or adjuvant Xerox after D2 gastrectomy. The results demonstrated that the SOX adjuvant chemotherapy was equal to adjuvant Xerox, and also superiority of SOX neoadjuvant chemotherapy was demonstrated compared to Xerox group. However, the compliance of the adjuvant chemotherapy of these patients were about 30% compared to scheduled treatment, and so still under discussion. Now in Japan, 3 new neoadjuvant setting studies are ongoing. One is Jacob 1509 Nagisa trial using SOX regimen, and other 2 trials are immunochemotherapy as neoadjuvant chemotherapy. Finally, I would like to touch upon the perspectives of stage 4 gastric cancer. To improve the survival of stage 4 gastric cancer, chemotherapy is not enough because chemotherapy and or targeting therapy cannot be continued long because of the resistance of the adverse events. Secondly, although the high response regimens have been established, the MST is still around 13 to 15 months. Thirdly, palliative gastrectomy is not beneficial except bleeding stenosis, so conversion therapy looks beneficial. Stage 4 is a complicated situation composed of peritoneal dissemination, hematological metastasis, and to distant lymph node metastasis. To understand more precisely and make the adequate strategy, I have proposed a new category classification of stage 4 gastric cancer as demonstrated in the slide. Initially, it is divided into macroscopically peritoneal dissemination, positive and negative. Then they are divided into 4 categories: potentially resectable metastasis, marginally resectable metastasis, and potentially unresectable metastasis, and non-curable metastasis. Neoadjuvant chemotherapy can be performed on category 1 and intensive chemotherapy for category 2, which at initial diagnosis operation was not the best choice. But with the successful chemotherapy, primary and/or metastatic lesion can be removed, and also volume reduction surgery can be performed in category 3, and for category 4, palliative chemotherapy. So roughly, conversion therapy is conducted in category 2 and part of 3, and really for category 4. Category 1 and 2 can aim at cure, but care is the main global goal of category 3 and 4. We have conducted international retrospective cohort study on conversion therapy for stage 4 gastric cancer combo GC1 study among Japan, Korea, and China, and successfully more than 2,000 patients were registered, and the results were presented in ASCO 2018. As demonstrated on the right side of the slide, MST of the R0 resected cases were more than 56 months, and the same tendency was observed in each category of the subclassification of the category. Now, in Japanese Gastric Cancer Association treatment guideline, these issues are described as the clinical question. Now, Madam Chair and ladies and gentlemen, summary and conclusion of my talk. Genetic analysis might help to lead precision oncology. Minimally invasive surgery, including ESD, laparoscopic surgery, are effective for early gastric cancer. D2 lymph node adenectomy of gastric cancer is regarded as standard surgical approach, and S1 capecitabine-based regimen using cisplatin, oxaliplatin, docetaxel is the standard treatment for stage 4 gastric cancer. Perioperative treatment can include survival of gastric cancer patients, and conversion therapy promising for stage 4, but further discussion should be made to establish global standard of the care of gastric cancer. I would especially like to thank all my colleagues in my department and friends and distinguished professors supporting my project. Thank you very much for your kind attention.